Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, my topic of discussion is about a common condition, common case which presents to our emergencies, and that is blood in eye, blood in anterior chamber of the eye. We call it hyphema in ophthalmology. So today we will discuss about its presentation, its different signs and symptoms, and possible treatments. This is an anterior segment or slit lamp photograph of a patient who has developed hyphema or blood in the eye anterior chamber, and it is visible with the naked eye even. And if we put this in photograph, slit lamp examination, we can see the accumulation of blood. Anteriorly, there is cornea, and posteriorly there is the lens in the human eye, and in between there is anterior chamber where there is blood. We call it hyphema. It is visible over there. This basically occurs due to rupture of blood vessels. We know that in iris or ciliary body there are blood vessels, and whenever these blood vessels are ruptured, there can be bleeding. So usually we find such patients after trauma. Child may be playing football, or sometimes road traffic injuries, any type of trauma that may be associated with the globe rupture when the eye is cut, or they may be blunt trauma when the eye is not cut or no laceration over there. So these blood vessels in the iris or ciliary body can bleed. So trauma is quite common cause of these type of hemorrhages, hyphemas. Along with it, sometimes these patients also develop new blood vessels. For example, diabetic patients, we know they are prone to develop new vessels in the eye. So they may develop in the retina and also in the angle of the eye, in the iris over there. But these are abnormal blood vessels. These are not normal blood vessels. So they are prone to bleeding, and we can see over there. Along with, sometimes there are different tumors, not very common but possible. For example, ciliary body or choroidal tumors, they can also lead to bleeding. Then some inflammations, viral inflammations like herpes simplex, herpes zoster virus infections, they can also cause this one. So we can say that mostly it is trauma patients which come to us, maybe blunt trauma. It may be possible to have airbag injury while driving the car, or any blunt punch or something. Or sometimes if there is no cut, it may be, if there is a cut over there, then of course the other structures are also distorted and damaged. So usually we find out these things, and here in this photograph we can see the structure is intact, but there is blood which can be seen even with the torchlight examination, but more precisely with the slit lamp machine which is used by the ophthalmologists. Whenever these patients present to us in emergency or we encounter them, we start with the examination. Our examination always starts with the visual acuity. The visual acuity in these patients is of course decreased, but it depends how much hyphema or blood is there. If the blood is extensive, it can block the visual pathway. Light cannot enter. The normal light which is passing through the aqueous humor and the lens, it can no longer pass properly. So they can directly block the light and the visual pathway. So the vision is decreased. And secondly, apart from this, they can also cause high intraocular pressure. high intraocular pressure. The reason is that the intraocular pressure is increased because normally there is aqueous humor in the anterior chamber, and when there is a blood over there, so this blood can block the trabecular meshwork, which is draining channels, and this blood can, even if this is extensive, it can block the pupil. So in this situation it causes pupillary block glaucoma. So all these things can increase the intraocular pressure, and that is a quite serious thing, because when eye pressure is increased, it affects the optic nerve, number one. And if it stays high for a time, there are chances of this blood to stain the cornea, which causes irreversible damage. So intraocular pressure monitoring is also very important. Apart from this, eye should be thoroughly examined for any cut, laceration, any corneal epithelial erosion, defect, CD, abrasion, conjunctival. So thoroughly it should be, and if possible, we should try to have a look at the retina. Once the globe rupture or any cut or laceration has been ruled out, we can do for the B scan also, that is ultrasound of the eye. And if we are suspecting any trauma, and we suspecting any bony injuries also and globe injuries, we can do CT scan immediately to see the eyeball integrity. It is same globe shaped or it is depressed from some sides. It can help us even to find out intraocular foreign bodies. So CT scan is also very helpful. So when we talk about these patients, apart from this examination, we have to keep two things, as I mentioned: the intraocular pressure, which can damage the optic nerve, and the second thing is that corneal blood staining. So now we will see what are the possible treatments in such situations which can be done. When we talk about the treatment consists of two parts. One is the medical part and one is the surgical part. When we talk about the medical part, it depends upon the extent of damage and injury. Of course, we are talking about blood in anterior chamber or hyphema, where there is no globe rupture. You can say it is blunt trauma. So in such situation, we can use topical steroids to control inflammation. Sometimes people also use a short course of systemic steroids also. This is just to control the inflammation. The second thing is the use of cycloplegics. For example, we have cyclopentolate eye drops and these things. The reason to use these cycloplegics is that normally the pupil is moving, dilating and constricting in the normal eye. So when we dilate it, we paralyze it for a time being, so that by dilatation and constriction, the chances of rebleeding are minimized. So cycloplegics can also be used in such patients. But if the intraocular pressure is already very high and we give cycloplegics, then dilating the pupil and dilating the iris can have a counter effect and can further increase the intraocular pressure by blocking the anterior chamber angle, the angle where there is all drainage is happening. Usually aqueous in an anterior chamber drains to the angle and into the trabecular meshwork and the canal of Schlemm. So this thing should also be kept in the mind. Second thing is the intraocular pressure measurement. If the intraocular pressure is extremely high, for example, if it is more than 60 for 2 days, and if it is more than 35 for 5 days, this is an indication to protect the optic nerve. It can damage the optic nerve. So we have to go for the surgical management. If there is also earlier corneal staining we are seeing over there, it is also an emergency. It needs surgical evacuation, because once corneal staining happens over there, then becomes very difficult to manage it. So when we talk about this medical management, cycloplegics and topical and systemic steroids we discussed. Some patients have got sickle cell anemia. These are special cases. In such patients, using carbonic anhydrase inhibitors, for example, acetazolamide, and even using hyperosmotic agents like mannitol IV solutions, they cannot be used, because they will further aggravate the sickling effect in these patients. So these are a few limitations. Also, we can use normally alpha agonists and beta blockers to control the intraocular pressure, but in patients with sickle cell anemia, apraclonidine or iobutine, they are relatively contraindicated because they can further aggravate sickling of the blood cells. So the question is how the blood in anterior chamber can cause glaucoma. We are talking about the blunt trauma. One, as I mentioned, that is pupillary block glaucoma, straightway. So much hemorrhage is there, it has blocked pupil. So there is no flow of blood aqueous from posterior chamber into the anterior chamber. So that may cause a pupil block glaucoma. The second is they may affect the anterior chamber angle, block over their trabecular meshwork, the channels which were draining. So much load is over there because of the red blood cells that the pressure is raised. This is another red blood cells glaucoma, we can say. And in the later stages, when the heme part is dissolved, gone over there, the empty RBCs can go and block the trabecular meshwork. This is another type of glaucoma which can happen later on, that is called ghost cell glaucomas. So all these things can damage. I'm talking particularly about the hyphema related. Otherwise, trauma, angle recession, all these things, that is another entity which we can discuss later on. But these two things can happen with these hyphemas. So this was basically the medical management, regular daily monitoring of intraocular pressure and measurement and daily photographs, or management of the size. It is decreasing, increasing. Patient is usually advised to keep the head in supine, a little elevated over there when he is having bed rest, 45 degrees, so that the red blood cells sediment downwards and don't get accumulated in the visual pathway. This is also helpful. Patient is advised not to do reading activities, because when you're reading and then you stop reading, the pupil undergoes movement. So this can further lead to bleeding and increase further intraocular pressure. So this was basically the medical management. Well, most of the hyphemas do get managed by the medical treatment, but there are some challenging cases, as I mentioned earlier, that if IOP is more than 60 for 2 days, or more than 30 or more than 35 for 7 days, optic nerve is going to be damaged. If IOP intraocular pressure is more than 25 for 5 days, corneal staining is happening over there. So these are the cases where we should not rely only on the medical management. Now we have to go for the surgical evacuation of the blood. The surgery is that simply can be done by irrigation and aspiration. Yes, and the blood clot is removed by washing over there. Alternatively, anterior vitrectomy cutter can also be used to remove the blood over there. So surgery is also an option in such challenging patients. But sometimes these patients have a tendency to rebleed over there. So regularly follow-up is also very important. When we talk about the complications, a number of complications can happen. As I mentioned, the first one was the glaucoma, corneal staining. There is blood in the eye, so there may be adhesions which we call peripheral anterior synecdoche or posterior synecdoche. Adhesions of iris with the lens can develop. Trabecular meshwork glaucoma, different types I discussed: pupillary block, red blood cell glaucoma, ghost cell glaucoma. These things can happen. And sometimes when the clot which has been formed over there retracts, there is rebleeding, which is even more than the primary bleeding. So these patients basically need regular monitoring and follow-up until this thing settles down over there. So this was basically a case which I just wanted to discuss, and it's of importance for ophthalmologists as well as family medicines or medical students, because we encounter such patients in our emergencies routinely, and this should be managed accordingly, according to the nature and severity of the disease and injury. I want to thank my respected audience for their attendance and attention. Thank you.